everyone. I'm glad you could join us on this rainy evening. I'm Howard Weiss, one of the neurologists specializing in Parkinson's here in Baltimore. It's my pleasure to introduce our speaker tonight, Dr. Sudhir Dutta. Dr. Dutta is a professor of medicine at the University of Maryland, and since 1991, he's been the director of the Division of Gastroenterology at Sinai Hospital. Dr. Dutta is a past president of the American College of Nutrition and has won many awards and honors in the field of gastroenterology. He also has a very interesting interest in the role of the GI tract in Parkinson's disease. We're certainly going to enjoy his comments and his wisdom. I'd like to introduce my friend and colleague, Dr. Sudhir Dutta, who's going to talk about Parkinson's disease and the gastrointestinal tract. Welcome, Dr. Dutta. Thank you.
Thank you, Howard. I've known Dr. Weiss for 30 years that I've been at Sinai Hospital. And he was introduced to me as one of the most brilliant neurologists in the town of Baltimore. And he has turned out to be that way. I mean, he's a clinician's clinician, and he's always been there if you needed his help. And Howard, thanks for thinking of us. When we were writing our paper on Parkinson's disease, I couldn't think of anybody else to review it than you, and you did it very graciously and in a timely manner, and it got published. So we are thankful to you for that. Parkinson's disease is not my forte by any stretch of imagination, but I've enjoyed reading about it ever since we got into this field because of microbiota. And I started the fecal microbiota transplantation at Sinai 11 years ago when one of my patients came to me who was also a PhD, and she said to me that she was getting recurrent episodes of C. diff infection and the antibiotics were not working, and she wanted me to give her fecal microbiota transplantation. And I said to her, "What is that?" And I did not know much about it. So I referred her to Larry Brent, who's a friend of mine in New York, and they were doing it at that time. But the state of art was really primitive at that time in that field. I called Larry and I said, "Larry, how do you do it?" I can't say those words on this, that he said, "Just take the crap, grind it up, and put it in." And I said, "Oh my God, I can't do that in Baltimore. It's far more sophisticated than that." So I told this patient that, "I'm sorry, you have to go to Dr. Brandt in New York." She went there. She wasn't happy with them. The cost was too much. She came back to me and she said, "If you don't do it, who else is going to do it?" So then I thought of it and I got it. I talked to microbiology department. I talked to people in regulatory department, IRB, etc., and they approved it luckily. And my nurses in GIDC were very happy to do it. And we started doing patients with C. diff. And I talked to Dr. Bartlett also, who was the first person who described C. diff infection at Hopkins. And he was just about the father of that. And he told me that, give your fecal microbiota from above and below both. And don't just stick with the lower part. So we did that. And lo and behold, we have had almost 95 to 98% success rate. Nobody else had that in the country. But nobody else gives it from above except the Dutch people in Amsterdam. They have been giving it through the oral cavity or through the stomach with an NG tube. So then in one of our research meetings, a gentleman who was a physician was suffering from Parkinson's disease, and he was reading about it, and he came and said that, why don't you consider this for Parkinson's disease? And again, I said, well, look, it's not as simple as you think, and the FDA has not approved it for a number of reasons. And so we just didn't get on this bandwagon of trying FMT in every conceivable disease that exists. We do it in a very selective way. We prepare it in the hospital, in the microbiology lab. We filter it. We try to give more science to it than it existed, than any science existed before that. But we started reading about connections between the central nervous system and the microbiota. And the more the group read, the more we realized that these connections are growing, and the evidence in this field is growing tremendously. Um, the evidence is still in many ways animal-based, anecdotal, um, but I think everything is suggesting that the GI tract does talk through to the brain. And we took a lead from there, and the suggestion of one of my colleagues here, Dr. Nair, who is a professor of uh, biochemistry uh, and nutrition at Bloomberg School. And he said, well, let's take on this. My colleague Sandeep Verma and I, we put together a paper where we studied the Parkinson's disease as best as we could and came up with a proposal where FMT will be given to Parkinson's patients with early disease. And the capsules are going to come from University of Minnesota that has agreed to provide these capsules. And they are specially prepared so that there is no virus or COVID-19 in them. And we have a neurologist who has agreed to do it with Dr. Weiss's blessing, Molly Del Cento. And we were just getting the FDA approval, which we got now, and hopefully within a month or two we'll start. And we hope that changing the microbiota might change the progression of Parkinson's disease. We all know, and I'm just learning with you guys, that Parkinson's disease occurs in males and in elderly people. But what I found was that from its first description by Dr. James Parkinson, English or a British physician, we have come a long way. And it's taken us about 200 years to accumulate the information that I'm going to share with you in the next 5 minutes. It is a chronic progressive neurodegenerative disorder, and each word has a very significant meaning. And I think more and more Parkinson's disease is being considered as a movement disorder or a neurodegenerative disorder. And Dr. Parkinson described it as, in his paper in 1817, calling it a shaking palsy. Tremors or pin rolling movement that I was taught, bradykinesia, slowness of the movement, including the slowness of swallowing, and then spasticity or stiffness of the muscles. Those three are the hallmarks of the disease. Otherwise, there is no really good marker until now that we have some scans that people are talking about to define this disease. And the primary lesion in substantia nigra, it took about almost 75 years before that was identified by a group in Paris. Dr. Weiss, you might have heard of these people. I did not know. Charcot was a neuroanatomist and a neurologist in Paris, in a hospital by name of Salpêtrière. And you guys, some of you may have worked there. And a beautiful hospital. And one of his students is the one who first pointed out that most likely Parkinson's disease is associated with changes in the midbrain area, in a pigmented area called substantia nigra. And it took another 75 years before we came to know that there is dopamine depletion in this particular part of the midbrain. It's a very surprising and very interesting story. Those of you who are interested, please read about it. This is a picture of Dr. James Parkinson. I was very much intrigued by his writing and the accuracy of what he wrote. The prevalence of the disease was very important for us because whenever you apply for any support system or grant, they always ask you about the magnitude of the problem. And about 1 million people in the United States have PD at a given point in time. And it increases, the number increase with the aging process. And there are a lot of epidemiological data that confirms and shows, depending on where you make the cut, 45 years or 60 years or 65 years, you find that the number of people really start rising very rapidly after age of 65. who have early Parkinson's disease. So, and the new cases every year are approximately 60,000, or 20 new cases per 100,000 of our US population. The male have higher frequency of the disease than females, on a ratio of 2 to 1. And again, that tells us about something about the genetic predisposition, and also the effect of these microbiota is different in males versus females. And there's a long story. We are studying about the Y chromosome and X chromosome and how that influences the microbiota of the GI tract. We now know that most of the bacteria that a child gets are from the mother. So most of the microbiota that we all receive are from our mothers, and then they get modulated throughout the life with the diet that we eat, and also by the antibiotics that we are given for different ailments. Most of the cases of Parkinson's disease are sporadic, and we have blamed chemicals in the environment and so on and so forth. The GI manifestations are quite well known actually, and precede the actual diagnosis of Parkinson's disease. Now, when I was a resident, I had heard about the fact that that dysphagia in some patients appear 5 to 10 years before manifestation of Parkinson's disease, but I didn't pay much attention to that at that time. But now this has become a very important part of linking these things together, which is microbiota in the GI tract and the neurological changes in the brain. We now know that dysphagia is as a result of perhaps alterations in the enteric plexuses, in the esophagus. Some of these are vagus branches, and some of them are, some of the upper ones are due to changes in the voluntary muscles in the pharyngeal area. And that leads to drooling, actually. If you don't have the ability to swallow, then a lot of saliva accumulates, and that causes so-called hypersalivation. But there is no increased salivation when they measured the saliva production on a daily basis or hourly basis. There's a lot of bloating because of bacteria in the small bowel that increase in number in the small bowel. And certainly they also increase in colon, and the constipation, which is a major problem in majority of our patients. And many of the people in the audience have asked questions related to that, because that's the area that we are most familiar with. I've been called many times in the hospital to help a patient with Parkinson's disease, severe constipation, and nothing works in terms of enemas and laxatives. And in many of these cases, we provide digital disinfection and literally a colon preparation that we give for colonoscopy. And many patients also develop altered defecation, which is based on alteration in the rectal muscle contractions and anal sphincter relaxation. If that doesn't happen in a certain sequence, then the process of defecation doesn't take place in a manner that we are used to. So these are some of the GI manifestations. There are also GI manifestations. They're also known as non-motor symptoms of Parkinson's disease. The connection between brain and the gut-brain connection, the idea has been developing for the last almost 50 years, but everybody was having a lot of trouble with it. It was not so easy to establish it until a number of people, neuroanatomists, who found that there were as many nerves and neurons in the GI tract as in the brain. When I first heard about it, and it came out in a book by Michael Efron from Columbia, actually. Many of you might know him. a brilliant guy. He was studying it for a long period of time when he counted the nerve cells in the colon and in the entire GI tract, and found that there were so many of these nerves that they were more than what is there in the brain, and he called it a second brain. Dr. Marvin Schuster, who was at Bayview in Baltimore, he was a great admirer of this area, and he told me before he passed away that this is not, the gut is not a second brain, it's the other brain. And he said, Sudhir, I'm not going to accept it. This is not a second. This is just the other brain, because just as important as the first brain, the nerve supply of the gut is interestingly such that it can also work in collaboration with the brain, but also if it is cut off from the brain or the spinal cord, it does have its function as well. And that's why it is now known as enteric nervous system. Evolutionary biology clearly suggests that ENS developed before CNS. So some people in this area who are very, very enthusiastic about it, they think that ENS needs more time for us to understand it than we have paid attention to it. The neurotransmitters that are there in the brain, and we use them for the treatment of different diseases, are all found in the GI tract. And Michael Efron was studying serotonin, which is 5-hydroxytryptamine, in 60s, almost 60 years ago. And he demonstrated how much nerves in the colon were taking up the serotonin. And there were serotonin receptors in the GI tract in very large quantities. And he was really amazed at that. Besides acetylcholine, which is well known, dopamine, norepinephrine, GABA or gamma aminobutyric acid, which is another neurotransmitter. All these are there in the GI tract. So you see some similarity between the two organ systems, and therefore the issue of connection between the two has been looming there, and we didn't know how to connect them. One was the vagus nerve, obviously, that the two are connected, and the vagus does modulate GI function. We all know that if you are under stress, the mouth dries up, saliva production goes down to zero. The gut literally seizes. And that was shown in many of the radiographic studies, that people who were scared, then the stomach was full of barium, it would not empty under any circumstances. Or if it was full of barium in the colon. So we know that there were connections between vagus and the GI tract for a long period of time, but how it functioned was not clear. And I think the story is unraveling slowly. As I mentioned to you, the Parkinson story itself took about 150 years for us just to know that the problem is in the brain, in the midbrain, and dopamine deficiency is the principal abnormalities. Is going to take probably much longer for us to figure out the connections between the two organ systems, which are exceedingly complex and dynamic. So the complexity is that the brain and its effect on gut physiology, highly variable, but we have examples of each one of them. Gut impacts on the brain function, that is also beginning to clear up. Patients with hepatic encephalopathy with altered microbiota, they have all kinds of fogginess in the brain. That's an example of that. In contrast to brain and GI tract, where IBS is an example of anxiety and stress causing diarrhea and constipation in these patients. And now we think that the microbes in the GI tract are also modulating the brain functions by producing certain compounds that presumably travel upwards or go into the systemic circulation and then get into the inside the brain. And we have known that the nutrients that we eat every day influence all three systems, the microbe, the gut, and the brain. So the story is really complex. It'll take a long time to unravel, if and when it unravels. So I don't have all the answers that you guys have asked, which are really very, very thoughtful, important questions, but we'll get to them at the end of this presentation. The pathogenesis of Parkinson's was always kind of unclear as to what was causing the depigmentation of substantia nigra, what was causing this change when these neurons begin to lose dopamine. That was not clear to anybody. And this was thought to be idiopathic or some toxins in the environment that presumably got into the brain and caused it. But the whole picture was quite unclear. We knew that the increasing age is associated with it, with changes in the midbrain section causing Parkinson's disease. Gender was associated with it. With the Y chromosome, it is more common in males. And now we are thinking of bacterial metabolites, which are mainly, short chain fatty acids or a whole bunch of derivatives of those that are causing this alteration in the brain function. Altered microbiota or bacterial dysbiosis is well described in a variety of conditions, but is best studied in patients with recurrent Clostridium difficile infection. We've been part of those studies in the last 10 years. And we have reported that the bacteria are completely changed as a result of antibiotics in a select group of patients who develop Clostridium difficile infection. And in that subgroup, there is a group that keeps on getting these infections again and again, and they're called recurrent C. diff infection patients. And the treatment of choice is clearly fecal microbiota transplantation in those patients. It works like a charm in them. And that has been a subject of study for a long period of time. We have known that there is increased permeability of the gut mucosa in certain situations, which allows bacterial antigen, viral antigen, and these molecules that the bacteria produce to get into the circulation, and some of them cross the blood-brain barrier and affect the brain function. Translocation of bacteria from the intestinal microbiome is well described under ischemic conditions where the supply is diminished or there's colitis, IBD, that is associated with it and is studied extensively now. So we're beginning to see shades of interaction between these bacteria, which we thought were so remote from the brain of the thought process, that maybe they're not so remote, that we are connected in more than one way that we had realized. And then these bacterial metabolites get into the lymph, blood, tissues, and then get to the brain. This idea has been further substantiated by these Lewy bodies, which have been recognized as a histological landmark or histological marker for Parkinson's disease in the brain. These are intracytoplasmic eosinophilic deposits, also known as alpha-synuclein. So these deposits are recognized by the pathologists very well. They were described almost 100 years ago, more than 100 years ago. But we did not know what they meant. We are seeing these Lewy bodies in the GI tract even earlier than they appear in the brain. And that's another piece of information that is beginning to make us think maybe in a subset of patients, the process may start in the GI tract. Believe me, I'm not a proponent of this idea, but this is just growing on its own merit. And a lot more need to be done before this becomes an established fact. As a scientist, all I can tell you is this is what we have. This is what we know. To connect these dots will take time. Now, about the GI symptoms, a couple of things that for the Parkinson's disease, I think we had no specific test, and Dr. Weiss probably knows more about it. This DAT test, a scanning test, I think is being used in the brain to determine if there is degranulation of substantia nigra. How good it is, I don't really know, but like most radionuclide tests, it probably has its own range of sensitivity and specificity. The non-motor functions are mainly constipation, bloating, dysphagia. People underreport them for many reasons, including the fact it is embarrassing to talk to your doctor about leakage of the stool, fecal incontinence, constipation, inability to pass stool, lack of also awareness on the part of the patients. So all of these have led to the fact that we have kept the two departments of the brain and the gut totally separate. We have not connected them until recently. And now it is opening up and people are becoming more comfortable in talking about the things that are taking place. This schematic diagram, I just put it in to tell you that the GI tract from the mouth to the other end is almost 24 to 26 feet long. And it is connected with the help of a very intricate neuronal system, the so-called enteric nervous system. And that enteric nervous system has, as neurotransmitters in it, all the molecules that we mentioned. So it's a very complicated system. It is connected to the brain directly with the help of vagus nerve. Vagus nerve comes from the base of the brain all the way along this esophagus and into the stomach. That part we knew. Vagotomies used to be done for peptic ulcer disease routinely in the 19th century because peptic ulcer disease was very common. It is only in our recent times, in the last 40 years, with the advent of H2 receptor blockers, proton pump inhibitors, that we have literally a disappearance of this disease. But prior to that, people used to have all the complications of acid peptic disease, and vagotomy used to be done. And interestingly, one of the observations that came from Denmark area was that the vagotomy patients have a much, much lower prevalence of Parkinson's disease. And that difference was very striking. The vagotomy patients has very few cases of Parkinson's disease. And that's interesting to know, although I have not seen any additional papers in this area. So I'm sure there are problems with that concept, but it is again pointing out to the relationship between the brain and the gut in different ways. I would now focus for a while, get away from the microbiota and talk to you about the problem of slowness of transit in Parkinson's disease. The entire GI tract slows down from top to the bottom. It's not only in the esophagus that things are slow, they are also slow in the stomach, called gastroparesis. They are slow in the small bowel, which results in bacterial overgrowth. And it is clearly slow in the colon. And numerous studies in the colon have been done to demonstrate in Parkinson's patients that we have sluggish, lazy colon because of presumed alterations in the nerves of the myenteric plexuses that are located between the muscles. And so the patients with this problem suffer from the problem of bloating and constipation, and they have nobody to relate it to you except relate to this problem, except now they can come and we have a whole bunch of tests now. We can study the transit time with the help of markers, SITS markers, or radiopaque markers. We can study anorectal dysfunction. A lot of this is being developed here at Bayview Hospital in Hopkins with the help of Dr. Schuster's work on anorectal manometry, the sphincter pressure, and his colleague White, who was there, and he's now at University of North Carolina. So they together worked in this area 40 years ago, and nobody was working on it. We can get defecography to record the entire process of defecation, which was never done before. We can measure pressures in the anal sphincter area, squeeze pressure, rectal compliance, electromyography. All of this is now doable, which was not there. The treatment obviously is both stimulation of the colon with a variety of products that are there, including Biscodil. We can also give biofeedback. particularly relevant to anorectal dysfunction, those who have inability to empty the stool or have leakage or diarrhea because of the overflow of the liquids from the colon, and the stool is sitting there in form of a block, and then the liquid flows out and causes incontinence. So it's a very complicated area, but nevertheless, we are beginning to see the end of it somehow. And I think we are better off now in treating it. When you give these are the 3 X-rays, abdominal X-rays. We do the colonic transit studies in our patients with idiopathic constipation. We also do it for Parkinson's patients as well. These are the little markers you can see. A normal patient, majority of them are gone within 48 hours. On the other hand, in patients with impaired colonic transit, like Parkinson's disease, which is right in the middle, they're scattered all over, or the patients who have advanced PD, then you have a lot more. The colon slows down. That's the message that we have for you. Now, many of you have asked the question about how to manage constipation, which is really a challenging problem in this field. And there is no simple answer. I try in my practice. Many of the things that are proven to be efficacious individually, but not together. Certainly every paper talks about increased physical activity, increases colonic motility, no doubt about it. Does it happen for Parkinson's disease? Yes, in the early stages, it definitely happens. Late stages, perhaps it doesn't, to the extent that we expect it to. Certainly taking fluids, increased fluid helps in keeping the stool soft. Dietary fiber, non-absorbable fibers, like psyllium is probably the best example of that. So we recommend to people a tablespoonful of that once or twice a day, depending on your limit of tolerance. Now, keep in mind, when you take fiber, Dr. Mendeloff, who was at Sinai, used to tell me that we don't tell our patients that when you take fiber, you also basically produce more gas. And that's fermentation factory of the colon. It produces, for every gram of fiber, 8 grams of gas, a lot of gas. That's why many people say, well, I can't take it because it makes me bloat. So we use fiber just to give a bulk, but the fiber, this has to come out of the colon, otherwise it's uncomfortable. So therefore, you need to give your patients a combination of osmotic laxative like Miralax or lactulose, or more likely some stimulants, direct stimulants, which is what I like to give to my patients. I tell them about all these things, which they know most of the time themselves. So I'm left with direct stimulants and dietary fiber type of thing that, depending on the tolerance, they take that. Psyllium products, and they also take Biscodil, if that works, 5 milligrams or 10 milligrams, or a suppository. Magnesium citrate tablets are available in the market now after a long time. Milk of magnesia has been there for times immemorial. Nobody prescribes it, nobody advertises it, and it works like a charm in majority of patients because magnesium is a very strong stimulant of the colonic smooth muscle, and that was recognized long time ago. At Mayo Clinic, Charlie Code did his experiments with the colonic muscles from the animals and showed that the magnesium ions are great stimulants. So I'm a proponent of trying magnesium salts in almost all my patients, including Parkinson's patients. It generally works and can work lifelong. How much has to be adjusted in each patient, has to be tailored to their diet, to their activities, disease process, et cetera, et cetera. Now, Senna is a product is a natural plant product. It's been around for a long time. It is anthraquinone glycoside and it works. It's available, it's dirt cheap. In some people, it causes cramps. And so I try colonic stimulants, either magnesium or Senna, and sometimes combination. And then come the other three new drugs that have come in the marketplace. And in that, I think Linzess or linaclotide has become most popular. Many of my patients with PD have Linzess, which is guanylate cyclase C agonist. When the cyclic AMP or guanylate cyclic cyclase is increased, then the motility is increased of the bowel. And this is a very well studied phenomenon. Some people get diarrhea and cramps, but I think Linzess works and has to be tried in small amounts or large amounts. It's available in many different compositions now or dosages. Lubiprostone, which is based on chloride channel activation. And chloride channels are the channels present in the colonic epithelial cells, and they also pass water. And this drug makes more water come into the colonic lumen and softens the stool. So lubiprostone or Amitiza and Linzess are the new products that do work in PD. The dose has to be adjusted very carefully, and not infrequently, it has to be combined with magnesium or Biscodil. That I find as probably the best solution for my patients with idiopathic constipation and or Parkinson's disease. The cisapride, proculopride is a serotonin product, actually, 5-hydroxytryptophan 4 agonist. It's an agonist. It was very popular, but then there were cases of cardiac arrhythmias and it was taken off the market. Now it has come back again, and I'm using it carefully and less frequently than I used to because the cardiac issues, but I think there were very rare cardiac issues with this. It is based on 5-hydroxytryptamine, which is also present in the brain. So that part is attractive to me. And as you probably know, many drugs are based on 5-hydroxytryptamine antagonism or agonist. For nausea, which is central nausea, we use them. They're all based on serotonin receptors in the brain. And there we go. So this is in a nutshell the treatment of constipation, which is quite complex. And this does not include the rectal problem that we talked about in the last slide, which is separate in a subgroup of patients with Parkinson's disease, where they are not able to, the stool is soft, but they are not able to evacuate it. And that's a much more challenging problem that we have. And we can talk about that more in question answer session later on. The so-called drooling or siluria, we always thought it was because of increased salivation in Parkinson's disease, but most studies have shown that if you collect whole saliva over time, it is not increased in these patients. In fact, it may be decreased many times. So why do they have so much drooling? Well, it turns out that they are not able to swallow that easily. The tongue muscles somehow become very stiff as a result of basal ganglionic lesions, and therefore this exists. And so there is bradykinesia in the tongue, back of the tongue, and the deglutition process, which heavily relies on the tongue muscles. If you have ever seen a video of fluoroscopy, you realize what the tongue does. It pushes it backwards into the direct channel of the GI tract. If that does not happen appropriately, then you have aspiration. Some of the liquid portion can leak into the trachea, causing pneumonia or cough. Cough is more common than pneumonias, and that is seen very often because of the failure of the muscles of the tongue plus the other pharyngeal muscles, which are also not working in coordination in our patients with Parkinson's disease. Now, what can help them? Well, nothing really helps in a very reliable way, to be honest. This area is fraught with problems from the therapy point of view. I tell my patients, to chew some gums and try to keep the movement at the back of the throat. And the SLP and nurses also advise the same thing, to keep on exercising is probably the word, exercising the muscles of deglutition in the back of the throat, or the gullet. And by taking some gums, sugarless products, and also head posture had to be improved to get it down. How much it works, I can't tell you, except to say that patients feel better, but the problem of coughing remains. And I don't have a very good answer for that at this point in time. People are looking into a whole variety of things, including botulinum toxin injection, which basically diminishes saliva secretion, and has been done. We haven't had any patient, but some of you in the audience may know or may have gone through the process. That may help. Cholinergic drugs, also known as acetylcholinesterase inhibitors, they supposedly also help this group of patients. So I'll be interested in hearing more from you about this. There isn't a lot of published information in this area because very difficult area to quantitate, measure, and reproduce studies in this area. The last part is small bowel dysfunction. Again, the fundamental process, as I mentioned, is that the peristalsis, the process of sequential contraction and relaxation in the GI tract, which starts from the gullet, goes all the way to the anus. That process gets dysfunctional in Parkinson's disease. And this results in diminished transit time or prolonged transit time in these patients. Things don't move as well. Bacteria grow a little bit more than usual, and that causes bacterial, so-called bacterial overgrowth. Now remember that there are bacteria present in the small bowel all the time, but the concentration is much, much lower. In patients with PD, the concentration goes up quite a bit. It is 10 to the power of 5 per ml of the jejunal fluid, which means 100,000 bacteria. With the bacterial overgrowth, it goes to million or much more, 10 to the power of 6 or 7. So, but the point of it is, the more bacteria grow because of impaired peristalsis, there is bloating. What do we do? Well, to establish the diagnosis, we use marker transit time studies to establish that indeed there is a problem of transit. We use hydrogen breath test, which is based on poor transit of lactulose, a sugar, through the small bowel, and is excreted in form of hydrogen, and we measure hydrogen in the breath. We can also collect fluids from the jejunum, and we can measure in the fluid concentration of bacteria, just as we do in the urine and many other fluids of the body. We can do that as well, and we do actually carry this out in some cases. The treatment ultimately is a non-absorbable antibiotic, rifaximin, which was brought to this country from Italy by Dr. Dupont, a colleague of mine. He is now in Houston, and it has become a very popular drug. It's very difficult to find it, actually. It's very expensive. Those of you who have seen it, but rifaximin is being used exclusively for SIBO, or the bacterial overgrowth syndrome, and also for the treatment of hepatic encephalopathy. In that field also, these are non-absorbable antibiotics. It changes the microbiota in such a way that the ammonia production goes down and encephalopathy gets improved. This is a schematic diagram, a little complicated, so I won't spend too much time on it. Suffice it to say that the gut-brain axis that we've talked about perhaps has connections through translocation of bacteria, translocation of metabolic products. Gut permeability plays a role, and the most important part is short-chain fatty acids that then goes through the circulation and reach the brain and alter the mucosa of the GI tract. They affect the microglial system in the CNS and impact on its function. That's the hypothesis that is now growing. These are also responsible for development of the alpha-synuclein fibrils in the enteric nervous system. And all this work is in progress right now, but all of it is based on inflammation, a subliminal inflammation, which we did not recognize before, which was not seen by the pathologist. By more new criteria, we are able to identify both in the nervous system and in the gut. So there is a level of inflammation that's going on, and the bacteria contribute significantly, and their metabolites contribute significantly. That's the concept we are developing. For the evaluation of dysphagia, I'm sure some of you may have gone through this. Video fluoroscopy is very common, where they give you barium to swallow and they take picture as you swallow. And we look at the swallowing process. And this has been now quantified quite a bit to give you some answer. We also do endoscopic evaluation, and then there's manometry now available that can then literally can show you the impaired peristalsis, prolonged transit time in the esophagus. These are the new tests that we have available. And this picture I put in just to show you that a normal barium swallow looks at the swallow from below C7 or cervical 7 down to the chest. It doesn't look at the oral cavity and back of the tongue and the pharyngeal area. And then here is where most of the problem takes place in these patients, where there is a gullet and you have entry into the esophagus and you have entry into the trachea. And that part can only be seen by these specialized pictures, which are pretty simple as far as I'm concerned, but they were not usually taken in most situations, but now we do. It's called video pharyngogram or video fluoroscopy, and that can study it in patients who have coughing spells or swallowing difficulty, and that was not done before. So I recommend you to consider this if and when you come across this kind of a problem. One of the questions was that can you have hunger pangs in Parkinson's disease? And the answer is right here, rapid transit time. In a group of patients, the stomach doesn't slow down, but has a rapid transit, shortening of the gastric contents, and they're dumped into the intestines very quickly, and you can get a hunger sensation. It is uncommon. In less than 10-15% of all patients with gastric dysfunction have this. Majority have gastroparesis, where the food or the barium just sits in the stomach and does not empty, and frequently causes nausea, early satiety, resulting in weight loss and bloating. So that is far more common than the dumping syndrome. It can easily be done by solid meal scintigraphy, by radiology. People do it. They give you a sandwich, an egg sandwich that you swallow, and then they monitor it with a gamma camera for 2 to 3 hours. So it's a 4-hour test, actually. What to do? Well, if you have nausea, early satiety, and truly have gastroparesis, remember we see gastroparesis mainly in diabetics. And in diabetics, it is mediated through the vagus neuropathy, and the stomach doesn't empty properly. What we recommend to them is frequently that they should take smaller meals, volume-wise, more frequent meals, and also meals that can be easily passed on from the stomach. The stomach has sensors for osmolarity and also for concentration. It will not release into the small intestine food unless it is ready to be received by the small intestine. And that's the job of the stomach, grinding it, converting it to a chyme, and then releasing it at a certain rate into the intestines. The intestine can act on it and digest. So it's a fairly complicated function that is lost in certain diseases, including vagotomy, diabetic neuropathies, and also in Parkinson's disease. And that causes problems for the patient. So My simple solution is, well, take lighter meals, smaller meals, frequent meals. And when we say lighter, it means less fat in the meat, less high proteins, because the meats and fats take a long time before they are released into the intestine. They are broken down, digested as much as possible in the stomach. And that is to be kept in mind. Lighter meals are mainly carbohydrate meals and small meals, basically. And a lot of liquids. Liquids are cleared much faster from the stomach than very hard, solid meals. So now there are a couple of drugs that help. The famous antibiotic erythromycin does a fairly good job of emptying the stomach fast. However, the problem with that is the effect doesn't last forever. It may last for a few weeks, but that's about it. But when we use it off and on as a temporary measure to improve the gastric emptying, the new drug domperidone is now becoming available, and it also contracts the the stomach muscle very aggressively, and that helps. Metoclopramide or Reglan that the surgeons use often is not good in Parkinson's disease patients because it crosses the blood-brain barrier and has many side effects with other drugs, central nervous system drugs. So we don't, at least I don't use it in Parkinson's patients. The last part, which we touched upon in the beginning, let me see how much time we have. We have maybe a few minutes to finish it. Let me just tell you that the Parkinson's disease may have gut dysbiosis, or the bacteria are altered because of the changes in the motility, the number of bacteria in this area change, but also the families change. The normal bacteria disappear, and many of the rare ones start showing up. Prevotella, Butyrococcus, Bacteroides fragilis, these have been specifically identified in the stool collected from patients with Parkinson's disease, lactobacilli included. But I often wonder whether lactobacilli were related to probiotics, because most probiotics contain lactobacillus. The treatment right now, folks, is rather rudimentary, rather primitive. We use probiotics. There are 305 different probiotics available in the market. We just prepared a review of that. Surprisingly, there are only 2 bacteria in them, and their species, Lactobacillus and Bifidobacterium. We don't have a whole host of bacteria that are going to be incorporated in the future probiotics, advanced probiotics that are coming down the line very soon. And when you go and read the label, they keep on emphasizing that it has billion CFUs or trillion CFUs, which refers to the number of bacteria. I'm not sure that anybody has demonstrated that increasing that number beyond a certain amount really makes a difference in terms of its efficacy. So the field of probiotics is out there, is more commercialized, and is on there on the basis of scientific fact. A large number of these bacteria are just thrown out of the GI tract. They are not able to adhere to the mucosa of the GI tract. And so we still have to find out what are the best probiotics for our patients. Number one, what is the quantity that they need to take? We still have to figure that out. And for different diseases, we're going to have different probiotics in the future. The bacteria that are needed in rheumatoid arthritis patients are different than in IBD patients versus PD patients. And you will see that developing in the next 5 to 10 years. Avoiding antibiotics is a very reasonable thing to do in just about everything. And I preach that, literally I preach it by saying that, look, antibiotics that have been given by the dentist and the urologist and everybody else, the GI people included, should be taken with great caution, with great trepidation, and only when you absolutely need them. When you have things like pneumonia, infected sinusitis, or dental abscess, then only you should take prophylactic antibiotics, absolutely not. and we are doing FMT, fecal microbiota transplantation in this group of patients to collect. This is the study design of our study that is going to be starting. Those of you who are interested may contact our office. It has not started yet, and there is pre-screening by the neurologist. There is then randomization into the capsules versus placebo, and then there is a crossover. Everybody gets capsules eventually over a period of almost 8 months or so. Everybody gets everything. And so the study is running up to almost 2 years now. That is the way it has been proposed. There is no other study like this in the world. There is one study going on in Houston, but the design is very different. If anybody is interested, you can call my office. They can put you in randomization process. Let me summarize. Several lines suggest that PD may start in GI tract, and I'm using these words literally may. I don't think we know it for sure, and this is only in a subselect group of patients. A large number of PD may be from other causes, direct toxicity of certain toxins. Symptoms predate the disease. Synuclein is the marker, histological marker, which is present in GI tract. Vagotomy lowers the risk. Alteration in fecal microbiota. All these observations are leading to the fact that yes, there is a connection between the two, the brain and the gut, and that the PD may have its onset in the ENS, enteric nervous system, through a variety of events in the guts, like leaky gut, infection, inflammation, dysbiosis, and inflammatory reaction, and that you will see in the future several new therapies, both for constipation. You will see many new probiotics and FMT. That's the hopeful thing that I hope materializes in the near future, because we have a lot of money driving technology these days in the Wall Street, and I hope some of it will trickle down into the proper channels. And this is my earnest hope, which will help my patients in the long run. Thank you all for your time. The hour is late. I apologize for the long presentation.
Well, that was certainly a wonderful, wonderful talk, and I thank Dr. Dutta so much. So much material was covered, and it's a difficult topic, but I really appreciate your help, Dr. Dutta.
Thank you. Thank you.
Do we have time for a couple questions? Yeah, maybe just a couple of questions, Sudhir, if you have a few moments in the audience.
Howard, there were about 20 questions that were turned in by the attendees.
I guess.
Do you want to finish it at 60 minutes, or do you carry on because I have time? I can spend more time.
A few questions. I guess a couple of the questions, I'll just sort of summarize them, talked about dietary changes for handling constipation, foods to avoid, foods to take.
Right. I mean, that's a very big question. Let me say to you that, first of all, the science in this area is still very limited. So I can't be dogmatic. I have to say everything with the said that maybe, yes, it will work, and that you have to try some of the things. It is that may or may not work. So it is a very soft recommendation. The dietary part, I would say to you that I have talked to many people in this field, and everybody says that what you're already reading actually online in lots of nutrition journals, that the processed food, particularly processed sugar, processed meats, are generally considered to be not healthy, both from the point of view of transit of the food through the GI tract and the variety of chemicals that they have that adversely influence the function of the GI tract. So organic, less processed food, and in that there is great emphasis because of pieces of information that are not directly addressing the issue, but suggesting that plant proteins, whole grain proteins, are much better, that animal proteins can be harmful, and therefore particularly red meat has been criticized from many different angles, including colon cancer. My take on it is that if the foods are organic, taken in moderation, and avoid antibiotics, probably the harmful effect is little or nothing. On the other hand, large quantities, which leads to obesity, which alters our metabolic system, which alters our immune system, are going to hurt us any way we slice it. Fish and the related meats like chicken and turkey are considered to be reasonably safe among proteins, but certainly plant proteins are considered to be superior in this field. For multiple sclerosis, I was amazed at some anecdotal cases, and they were doctors who were diagnosed in MS, were taking steroids. When they were put on vegan diet, an organic diet, they came off steroids. Now, I don't have the long-term follow-up on these physicians who were presented in one of our nutrition conferences, but it was still, to me, mind-boggling that this can happen, that these diseases can be reversed and temporarily halted or slowed in their progression, which I never thought of, short of giving steroids and some very, in the long run, dangerous chemicals that we have. And this is happening to our IBD patients also. And we are applying the same dietary recommendations that I'm making right now for the PD or Parkinson's disease patients also, because there is an element of inflammation in the bowel that is being recognized as leaky gut. And these are some of these chemicals and molecules are leaking. Now, we haven't been able to identify most of these, so it is very hard to pinpoint as to what these products are. But in general, please adhere to more plant-based diet, organic diet, containing fish and perhaps turkey and chicken, who are grown on the farms in a different way. I was just amazed, even the milk, the way it is produced, and the cows who are kept constantly pregnant, and their diets have been totally altered to maximize milk production. Obviously, milk has changed completely. It is not the same milk that it used to be 100 years ago. So that's my best advice, which is all over the place in Oprah's journals and nutrition journals. And high sugar content is certainly, and whenever you read about these zero diets, please be aware that each one of them has synthetic sugars, erythritol, saccharomycin, or phenylalanine products that they are there, and they cause sweetness, but they are metabolized totally differently, and they're metabolized by your bacteria, and the bacteria change in your bowel. So there's no shortcut to this. I think we have to go through the discipline of avoiding processed food, very high animal fat containing food, red meats, and more vegetable and plants and whole greens. I think I'm sure you're sick and tired of hearing all this, but that's the best advice I can do.
Dr. Dutta is the past president of the American College of Nutrition. But we have a couple questions about many of our Parkinson patients have difficulty maintaining their body weight. So as opposed to big problem in the United States with obesity, many of our patients with longstanding Parkinson's disease are losing weight, and they really don't know how to handle that. What do you have to say about that, Sudhir?
Right, that's a difficult topic. You have to go case by case. And what I usually do, first of all, I look at the actual weight. Some people tell me they've lost weight. When I actually try to document it, there is really no weight loss. Machines have to be calibrated, and if it is more than 10 pounds, then I get perturbed. Then I get, well, this is clinically significant. Something is going on, and we obviously do a run of blood tests, blood chemistries to rule out any infectious process, malabsorption process, or malignancy. And there's a whole workup if you realize that that's the case. But assuming that all of that has been done in a Parkinson's disease patient who does not have any other problems, it is most likely related to sluggishness of the colon and the sluggishness of the stomach. And so I tried to help them by suggesting what I mentioned in the talk, smaller meals, frequent meals, supplemental foods as well. But most of them don't like supplemental foods because they don't taste so good. But ensure vitals, and so a whole variety of them are out there. You can choose the flavors you like, but I encourage them a lot to take more calories, more caloric intake, but they also have to expel out these calories, not get bloated with them. And that's the biggest challenge in the PD patient, but every patient is different. Sometimes just increasing the caloric intake, increasing the physical activity is able to get them on track, and the weight loss process diminishes. On the other hand, if it doesn't, then the workup has to be carried out of malabsorption, maldigestion, and slow transit time. That has to be all evaluated. And then you have to go to pharmacological things to accelerate the process. That's all I can say, Howard, in this. It's a very complicated and more difficult patient.
Here's a common question that I get in the office. How do you strike a balance between the need to stay well hydrated to reduce constipation and the fact that many Parkinson patients are up frequently at night urinating and want to avoid?
Yeah, I know. I saw that. It's a very challenging case. As you know, most of our audience is a very well-educated audience. Most of people are very bright, intellectual people. They read more about it than I would know. So I usually learn from my patients. When I was in the VA, I used to call them my heroes because I learned always something from them by just listening to them, and what worked and what didn't work in a given patient. So that is a real dilemma in patients who have prostate problems or bladder problems. Drinking too much water does create problems. So I was going to say that titrate the water intake to the level of your tolerance. Also distribute drinking more in the daytime, and slow it down before going to bed, because you don't want to wake up 3 or 4 times at nighttime to empty the bladder. But this is a good question. Hydration is a problem. It's a delicate balance. But I don't know of any other solution or any other way of doing it, except keeping in mind that do it in the daytime, slow it down in the evening, and take it to the limit of your tolerance. You can't overdo it. Just because the doctor said you drink 4 liters, you can't do it. You can't do it. You have to stick to 2 liters that you're comfortable with. That's the limit. Yeah.
What about the role of medications in causing constipation?
Yeah, that's a very good question, complicated questions. And many of our medications, from metformin, which we use for metabolic syndrome, diabetes, etc., to a whole variety of these medications, they are constipating. They also alter our microbiome. And there is no easy solution to that problem. The first line of defense in this area or treatment is going to be change your microbiota. I'm a strong proponent of telling people that instead of taking probiotic tablets, take yogurt and take kefir, the East European yogurt. The bacteria in them, again, not very well defined quantitatively, probably variable from one bottle to another, but kefir and yogurts on a daily basis, I prescribe it for my patients. The amount remains undefined. Again, they have to define it for themselves. Many times we start with 2 ounces or 60 ml. If that causes bloating or diarrhea, we back off a little bit. That is the beginning. Then we go with the psyllium and magnesium salts. That's our line. And I recommend to the patients, don't worry about the fact that they worry about this is becoming habitual. Well, your blood pressure treatment, diabetes treatment, thyroid, we just have to use these medications to our advantage. So the patients have to take what makes their bowels move on a regular basis and not to worry about dependence. It does occur, but it occurs over a very long period of time, 10 to 20 years. And there is always a solution to that by adding another stool softener or laxative. So I would say to all my patients, don't be scared, don't be worried. Besides doing the basic things, physical activity, drinking water, fiber in your diet, start with whatever works for you. Now, many of my patients say, well, my grandmother gives me prune juice or I take prunes. If that works, wonderful, go with it. If it doesn't, then try psyllium and magnesium salts. If that doesn't work, then I go with linzess and amethysa and combination thereof.
And there may be one last question. In this, the patient wrote about intussusception, but in a simpler way. Maybe you could tell us that sometimes constipation could be life-threatening. Maybe if you want to just describe that, not to scare our audience, but to just.
Yeah, I looked it up, when I saw that question, is a very important question. I couldn't find any good correlation with intussusception. Intussusception is usually seen with the tumors of the small bowel. It rarely occurs in colon. And in the small bowel, in PD patients, we don't have that much of stool sitting. It is mainly in the colon. The problem that I see more often are diverticulitis and colitis type of inflammation in this group of patients, and then proctitis, stercoral ulcers in the rectum because the stool is sitting there like a block for a long period of time. Those are the things I see, and they give the picture of obstruction, but actually they are not obstruction, only partial obstructions, I should say.
Actually, there's something that called, that the audience may not be familiar, called volvulus that I've seen.
Yeah, the volvulus can occur. You're right. The volvulus occurs over time when the bowels are chronically constipated and become dilated over time. And when they become dilated, they get longer and dilated. Then they begin to twist on themselves. So we do see volvulus in older people, chronically constipated people. And many times the treatment is sigmoid resection is probably the easiest way. We are able to endoscopically decompress majority of these people. But the limitation of what we do is that it keeps coming back again and again. After a year or two, volvulus occurs again. So depending on a clinical situation, comorbidities, etc., we decide whether to just decompress a patient and put them on stool softeners and laxatives, and hopefully this will never happen again. Or sometimes if it is recurrent and the constipation is persistent, then we recommend sigmoid resection.
But I think the lesson I always tell my patients who've heard about this is be proactive. Don't let your constipation get out of control. That's the best way to prevent this.
I agree. I agree.
I want to thank you so much and for sharing your thoughts and your wisdom with us. And
thank you.
I hope
you, Howard.
Patients may show some interest in participating in your research studies about the microbiota. And I think it's a very interesting area that needs to be explored. So thank you very much.
Thank you for the opportunity. Thank you all. And thank you to all my colleagues and partners who have encouraged us to stay in it. And thank you to Molly Del Santo, Howard. You put us in touch with her, and hopefully the study will go forward, and we will report to you in a few years if it works. Thank you all. Good night. Appreciate it.